Start.
Good evening, my audience. Today we'll continue talking about the CT perfusion, and we come to part 2, and we will discuss the pathophysiology of acute ischemic stroke. First, we have to know that blood flow is critical to the functionality of any organ, including the brain, since it provides the essential nutrients and oxygen. And in case of flow disruption, the body auto-regulates the flow and pressure either by altering blood flow by collateral pathway or altering the blood volume or both together. Any reduction in the normal perfusion pressure results in vasodilatation and hence increased blood volume and transit time. In the brain, there are fairly well-defined thresholds for the cerebral blood flow values in normal cases, irreversibly damaged cases, and in nucleatic tissue cases. Let's take this example of vascular occlusion in the brain. This is a major segment occlusion of the right middle cerebral artery, and this is the affected zone of the brain along the territory of the right middle cerebral artery. And this is what we say about the finding of collateral pathway through the anterior cerebral artery. And autoregulation immediately will start after the onset of this vascular major occlusion. We say that we have a threshold for the brain to withstand the limit of blood flow and reduction of blood flow. The normal blood flow is 60 ml per minute per 100 gram, and the reduced blood flow values below this level will bring the brain into a phase of hypoperfusion. This is the general term for what happens to the brain secondary to the occlusion, and if we consider the time parameter, this hypoperfusion will start changing from mild to moderate to severe, and the phase will be named according to this time parameter. The brain here starts its autoregulation process by arterial dilatation to lower the resistance and subsequently increase the flow. And as we mentioned before, this vasodilatation will result in increase in the transit time. So the brain will do anything to preserve cerebral blood flow, and mainly by the two mechanisms, recruit collaterals and arterial dilatation. Let's go in detail what is the effect on the parameters. The time we agreed is increased, so all parameters of time assessment in perfusion scan will be increased. The volume by arterial dilatation will be initially increased. The flow, which is the most important, is initially maintained by this simple autoregulation process, and subsequently the delivery and extraction of oxygen. And the cell will maintain its function in that period of time. So let's go again and put the number or value of the cerebral blood flow against the time element, and this is the whole phase that the brain will go into secondary to occlusion, which is called hypoperfusion. If the blood flow value keeps in the range of 50 to 60 and above 30, this is still benign hypoperfusion, and we call it benign oligemia. Benign oligemia is defined as the phase of ischemia or hypoperfusion when the brain ability to auto-regulate the cerebral blood flow by vasodilatation is exceeded, and cerebral blood flow starts to be reduced, and of course the cell in this period of time is functioning well and patient is asymptomatic. But when we approach the level of reduced cerebral blood flow to the 22 ml per 100 gram per minute, the cell starts suffering from the reducing of the cerebral blood flow. And we'll go into another important phase of ischemia, of hypoperfusion, which is called brain ischemia. And brain ischemia is divided into two parts, which is the penumbra and infarct core. According to the CBF values, let's again put the CBF value against the phase and the state of the brain. If the cerebral blood flow become obviously in the range of 22 to 12, this phase is called the penumbra phase, and here we are starting to have electrical failure of synapsing and transmission of electrical brain function, and there will be an element of cellular dysfunction, and patients start to be symptomatic. If the value of the cerebral blood flow continue to drop and become in the range of 10 and below, this will goes into the state of pure and complete infarct core, where the brain cell membrane of the cell of the brain is damaged, disrupted, and there is complete irreversibility of the cell function and cell death. So we have hypoperfusion, which is the status that the brain will go diffusely in according to the occlusion. Benign polygemia is the first phase of hypoperfusion, where there is drop of the CBF, but to a limited value which is above 22 ml per minute per 100 milligram, and the patient is asymptomatic. If we approach the level of a 22 ml, we will go into the ischemia phase, which includes the penumbra, where the cerebral blood flow is between 20 and 12 ml, and infarct core, where the cerebral blood flow is below 10 and the cell is completely damaged. This is to remind you with the two important phases of ischemia. In the early time period, let's say the 1 to 2 hours, there is a large chance of penumbra, although the cerebral blood flow is reaching the risk level of 22 to 12. And with time processing, there is high chance of transformation into a completely dead cell and dysfunction, and markedly reduced penumbra value or chance, and the patient after 6 hours, almost all the area is completely infarcted and no benefit from reperfusion. This is a simple diagram to demonstrate these stages. And if we consider the normal phase, cerebral blood flow and volume and time are normal. If we go into the autoregulation phase, the blood flow is maintained, volume is initially increased due to dilatation, and time is increased secondary to the dilatation. And also, if we go into the benign polygemia, there is initially minimal decrease in the cerebral blood flow, although the cerebral blood volume is maintained and the time is keeping increasing. Penumbra, there is moderate decrease in the flow, moderate increase in the time, but the volume is preserved. And in the core, this is a severe form of hypoperfusion, where the time parameters are markedly increased and the flow and volume are markedly decreased. Just to remind, we put the markers and along the phase, benign polygemia, penumbra, and core, and we said previously the effect of these phases on the parameters. Now we'll come to the major question. After we understand the effect of the pathophysiology and on the parameters that we agreed, the time and volume and the flow, we'll answer the question how to make perfusion maps color images. This is, the answer of course is a purely software algorithmic analysis type, and we depend on two methods for that. I'll come shortly and quickly over them, because just we need to know the idea and not the details. The old method is called maximum slope method, and the new method is called deconvolution method. The maximum slope method, if we remember the time attenuation curve, this is the cell parenchyma and capillary network level. This is the artery and this is the vein. Of course, the vein is neglected in our study, and we have the wave for the tissue and wave for the artery to be analyzed. And this is the diagram that all of us can see it on the net regarding the formation and evaluation calculation of the parameters. This is the represented wave of the cell tissue, capillary network, and this is the density versus the time. The volume under the curve is representing the volume of the cerebral blood volume, and the slope, the high slope of the curve from the bottom to the top of enhancement is representing the cerebral blood flow. And if we remember the equation of the cerebral blood flow equal volume over time, we can calculate the mean transit time by dividing the cerebral blood volume over the flow. Here we have to add one important marker of time, which is time to peak, which is how much time is needed from 0 point to reach the maximum enhancement of the cell in the pixel which is under evaluation. All the time parameters, whatever the name of the parameter, is increasingly abnormal during the phases of hypoperfusion, penumbra, whatever, benign edema and infarction. This is the standard pathology. And also I have to add one term which is very important. The time parameter in the evaluation of perfusion maps represents the maximum area of hypoperfusion. So consider the time factor is very important to start with when evaluating the perfusion maps. The second important method is the deconvolution method. First, let's know what is the meaning of deconvolution. Deconvolution is the process of resolving something into its constituent elements to separate their effects by mathematically algorithmic analysis. If we want to understand it more, let's take this very nice example. And this example is taking the pouring milk into a glass of coffee. Let's understand what happens if we pour milk into the glass of coffee and apply it for the deconvolution concept and how we evaluate our capillary network. The pouring milk into the coffee is representative of the contrast injection, and this will evaluate the arterial input function. The stirring of milk and coffee that we do after pouring is done by the vascular flow and tissue characteristic of the cell that under evaluation, and this will be represented by the tissue function, TF. So we have arterial input function by pouring, and we have the tissue function by stirring the milk and coffee. Looking at the mixing together is representing the perfusion CT analysis, and furthermore the deconvolution process is specifically trying to figure out how much of the mix is due to pouring and how much of the milk is due to stirring, how much is due to the arterial input function and how much is due to the tissue characteristic function. And we come by conclusion of the deconvolution process to the item which is tissue residue, and this is explained by how much milk or contrast or blood is present in the area after pouring and stirring. This is a nice example to demonstrate the principle of deconvolution, which is retaining again the elements to its initial concepts and try to separate it and try to study their effects, and we can of course neglect or eliminate any part to study other parts. From the deconvolution process, we come to a new time parameter called Tmax, time to maximum of tissue function, which is the delay time between contrast in a major artery before the parenchymal region of interest, to the arterial circulation, to the parenchymal enhancement and mixing and hemodynamics that occur at cell level. This time is called time of max, and also it reflects the maximum hypoperfusion area and should be the first something to interpret when we are dealing with perfusion CT interpretation. Now we'll come to the aim and the goal of our discussion after we put the pathophysiology principles and how the methods of making the color images, which is a purely software and computer system, and differ from company to company, Siemens from GE, whatever. I will not forget name of other companies. And we'll come to the true examples of how to read CT perfusion color maps. One of the types of reading is called the eyeballing readings, but before we start with that, we'll have to depend on the fact that eyeballing is helpful in the extreme cases, when we are dealing with a major vessel occlusion and we know the territory. But in equivocal cases or undetermined cases, we have to rely on the mathematically automated calculation of color and according to the values which are known to us, volume and flow and time. This case is benign oligemia case. How we describe it? This is the mean transit time. There is an area of increased color in the left hemisphere compared to the right hemisphere, which denotes the area of hypoperfusion. If we go to the cerebral blood flow representative code map and the volume representative code map, we can't find any abnormality in the color between the two hemispheres. So we are left with only increased time with normal flow and normal volume, and this is what we say about the benign oligemia, which is the earliest phase and almost totally reversible, and patient is asymptomatic, although cannot be ignored. We'll see example later on that if you ignore this finding, the infarction will progress and the results will be hazardous. Second example. This is an example of penumbra. Let's start with the time parameter. We have this area of abnormal color increase in the right frontal, frontoparietal, parasagittal, extending to the level of the sagittal mid part of the brain and posterior aspect of the parietal lobe. And this is the cerebral blood flow. Obvious increased color compared to the left side in the area representative of the time abnormality. Similar distribution of signal abnormalities. And if we go to the volume is normal, both hemispheres show no abnormality. So we are having increased time and moderate decreased flow. This is typical penumbra. Okay? Now we'll go to the third example. Third example is pure ischemic core. Now we have the time code, color code. We have this area of abnormal color representative to the background and right hemisphere, which indicates an area of hypoperfusion. The flow is markedly decreased, very obvious signal drop compared to the right side, and it is matching the time abnormal signal. And in the volume assessment, we have also matching of the loss of signal abnormality. So we are having what we said before, markedly increased time, markedly decreased flow, markedly decreased volume, complete matching between the three abnormal color maps indicators, and this is an area of complete ischemic core and no evidence of penumbra or salvageable tissue. Another example. This is representative of the time. We have this large area of hypoperfusion, and in the CBF flow we have similar area of reduced signal which is matching the time, but in the volume assessment we have only small area of reduced volume in the right basal ganglia and putamen, and this indicates large mismatch between the volume and time and flow parameters, which indicates we have a small area of infarct core, large area of penumbra, and the patient is a good candidate for reperfusion. This is another example of matching between the time, flow, and volume, and indicates a complete, very good CBF and volume, no mismatch and complete matching, which indicates a large ischemic core and presumably very tiny penumbra in this region. This is a complete case where we have in the non-contrast study hyperdense signal of density in the middle cerebral artery, which indicates thrombus, occlusion in the angio-related images, and in the color map images we have complete match between flow, time, and volume, and the patient is known as a complete left middle cerebral occlusion. This is another different example. We have here hyperdensity in the part, along the part of the left middle cerebral artery. This is the documented defect in the left middle cerebral artery, and this is the color matched images. Here the time parameter describe left temporal and parietal area of increased signal, which is matching the flow, although the volume showed a very restricted area in the posterior aspect of the temporal lobe on the left side. So according to the result, there is benefit from reperfusion, and this is the related angio image. This is the occluded left middle cerebral artery, and after reperfusion, this is the complete, the reopening and the flow in the left middle cerebral artery, which indicates good response, and the patient escaped and is in good condition compared to what was presumed to happen if we left it untreated. For cases of small lacunar infarct, this is an example. Here very tiny increased time parameter in the right internal capsule, matching with the cerebral blood flow, but no value of volume loss, which indicates this is not a complete infarction, and this is true when we do follow-up per diffusion images. There is minimal residual diffusion restriction, which indicates patient is recovering because it is not an infarction. MRI, same principle as the CT scan, but the difference is we compare the mismatching is between the diffusion and perfusion MRI images. This is a positive restricted diffusion in the right cerebral hemisphere. By the way, the diffusion restriction in MRI represents the infarct core, and the MRI perfusion maps indicates what is penumbra and compared to the core inside. Here we find a difference and mismatch between the area of MRI perfusion compared to the diffusion, which indicates there is a large penumbra compared to the central part of infarct. And the final case, we will discuss how if we neglect the time parameter, this is a time parameter which is indicating high area of perfusion at risk, and the initial diffusion images demonstrates only restricted diffusion in this basal ganglia and posterior parietal lobe. However, the patient was neglected and left without treatment, and 3 days later there was a progression of infarction, and the infarction along the left middle cerebral artery was completed, and we lost what we are hoping to do according to our interpretation. And this is the end of our talk about perfusion. I hope it was a clear talk, informative talk, and easy, as we mentioned before, interpretation way for the perfusion. Thank you, and hope to see you in another lecture.